same email address. Hotmail, not AOL, but. Yeah.
Were you able to type your full name without it? Like,
Actually, Will Jackson,
Oh, yeah.
yeah, and I didn't, like, I was a conspiracy theorist already at that point. My college basketball number, and the year I graduated high school, so
Okay, good.
if you wanna find me. So on that note, yeah, just wanted to get an idea overall, just familiarity with TMJ, feel good. I know Tina, you have some background, but beyond that,
Exposure to it, but
exposure, nada.
4 out of 10.
No, very
I've done a course in Brazil, craniofacial rehabilitation,
Okay.
and I've done the surgery myself, so I think
You have some
personal
background.
experience.
Yes, okay. What kinds of surgeries you have?
It was the orthognathic surgery with the TMJ anchored on both sides. So.
Okay.
Yeah.
Alright.
so.
Okay. Was it a Rockabato course? Are you familiar with Rockabatos?
No.
Okay.
Shoot. Yeah, no.
No worries.
I'm forgetting the class name I did. It's one of those. It's like a common. They do a bunch of classes, Summit or something like that. But
Okay.
but just treating a little bit with that. I had some mentoring with it, so just want to learn more. But yeah, but it was cool. Yeah,
Okay, sounds good.
fresh up.
Not much, just
No.
from school.
Just for school.
Same.
Okay, all right. Well, part of my goal, just to be, so today's lecture, I'll be honest, it's a lot of anatomy and not heady, because I'm not heady. I like to be very practical, and so but with this lecture, you have to have some foundations of anatomy. And part of it is there's a lot of, just like any diagnosis, there's a lot of different classifications, a lot of different ways that you can think about treating the TMJ. But from my background, which I do have a little bit, again, went through the program, same as you guys, but I think a little bit more osteopathic, and you guys know those, move on, or if it's stiff, let's loosen it up. If it's hypermobile, let's strengthen it. And so we want to understand pathoanatomy, we're going to talk about that, but if you understand, again, the underlying structures and potentially what's happening, you're going to have a good idea of how to treat it, even if you don't know exactly what's going on, right? But if conceptually you understand anatomically what potentially could be happening, you're going to have a better idea of knowing how to treat it. So am I expecting you to memorize all this anatomy? No, but, well, yes, in some regards. Because it's the other thing I often say. Any of you guys taken, or how many OCS yet? Anybody one? Was there a few TMJ class questions?
Yeah.
In my experience, and with a lot of people, there's actually a lot of TMJ questions. Most of them are, though, if you understand the basic anatomy, and you can conceptualize things, then you're going to be okay. And so that's what I want to do today, is give you some of these foundations, again, understanding anatomy, and then how that could practically apply within your patient. So with that, let's go ahead and jump in. So like any class, we're going to make sure we understand our objectives, you're going to have a lot of objections, objectives, and it is a technology day today. We got 1 out of 2, at least that's working, but I can come here. I already mentioned this, we're going to discuss the anatomy. And just right off the bat, this is part of the difficulty of looking in research, just like a lot of things, is TMJ. So when I teach my class, I sit to patients, I'll say, if you want to look smart in front of your doctor, then don't say I have TMJ, say I have TMD, or orofacial pain, or temporomandibular dysfunction, or craniomandibular dysfunction, because there's all these different names. TMJ is just the anatomy. And so I'm going to sprinkle in different titles to temporomandibular dysfunction, because you're going to see it. So here I chose to put temporomandibular dysfunction. Later, you'll see it's called craniofacial pain. Later, I might call it orofacial pain. All of these are describing the same phenomenon. So, basic anatomy, craniomandibular system. But again, you think about the anatomy, cranium, mandible, kind of makes sense why they would call it that, versus TMJ, we're getting very specific, aren't we, to a joint. And that's what they used to think, is it's just a joint. But as we know, are things just that simple? Just one thing contributing to, or is it often a bit more complex? Arthrokinematics and osteokinematics, so those words are probably really scary. PTSD from PT school. But again, these foundational principles I think are helpful. If you can think about them, then you're going to understand a little bit more of what's going on. Why is it clicking early versus late? What could this be? Why is this happening? And again, if you have a basic understanding of the arthrokinematics, the osteokinematics, you can conceptualize and problem solve what we're trying to teach you, clinical reasoning, to understand what potentially is going on. Influence of body morphology. So this is another one that we'll get into the history, but a lot of people think this is just a dental issue. And so all they're going to look at then is the teeth. But we're going to look at body morphology in different ways, that if someone has a little bit rounder face versus a longer face, you're going to have an idea of if they're more predisposed to temporomandibular dysfunction even. And then what we are really, really good at is our bread and butter is body morphology as a whole. So is there actually a correlation between posture and temporomandibular dysfunction? There is. And again, I joke with my patients, like, it's true, when I was in PT school, they told me that, and I'm like, seriously? It doesn't really make that much sense. But even that, I'm hoping that it will make a little bit more sense based on the anatomy, and then when you understand the anatomy more, it's going to be like, oh yeah, this does make sense. And then when you talk to your patients, if you understand it more yourself, you're going to be able to speak to your patients in a way more authoritative and convictional way. Like, this really is a big deal. And so you really need to change, versus if you're like, yeah, I read it in the research, posture has an effect, but if you can explain it to them in a way that makes sense to you and them, compliance is going to be way better. Does that make sense? And then we're going to get into so symptom pattern recognition, what you guys are working on, what you've been drilled down, so understanding some of the most common dysfunctions, but just like a lot of the different areas, the most common dysfunctions. We're not going to get into some of because there's a lot of minutia, like a lot of different parts of our body, and so but even with that, do you need to know the exact minutia, or do you need to know how to treat the joint and the muscular system around it? Most of the time, you're going to be able to get them better with that. And then specific treatment techniques based on literature above. Fair? Okay. So why me? Why am I teaching this class? And we already know this. This is my lovely wife. She's a dental hygienist by trade. That's my now 20-year-old daughter who's getting ready for nursing school. So just a few years ago. So my wife and I she went to dental hygiene school, same time I was in PT school. It was kind of cool, actually. We had a professor, one of my PT professors, his wife was a dental hygienist, and so he was in the TMJ. And so right from the start, my wife was injecting me with all kinds of, first it was the orange, and then it was me. When she was in hygiene school, and so then I was like, get it, all the manipulative techniques, mine was sometimes rough like that, but she can sick me with a needle, I can do manipulation, right? So we just had that. We were that weird. We just got married literally right before we started grad school, and so we're looking at our pathology textbooks together, and it's like, oh, that's gross but cool. Looking back, there's a lot of crazy oral disgustingness, cancers and all those things. So all that being said, it was an interest right away for me. So went through the fellowship like you guys, and part of it, I'll just be honest, it was kind of, I had that interest and nobody else did. So I was like, I guess I'll step up, and because a lot of people don't like to treat it, as you well know. And like I said, my desire is to demystify it. It's actually a fun thing to treat. One of the things I really like to treat, though, is the cervical spine. I just find a lot of joy. People get better. I can use my hands, and I've developed over the years. I think my hands have gotten better. And it's one joint that you can make significant change in a short amount of time. And so then to couple that with, like, over the last 20 years as a PT, I've learned more and more about how to treat. Before it was like all I treated was the neck, and a lot of people got better. So that was one of like, yes. And then I had these patients so that they wouldn't get better. And so then, case-based learning, taking a lot of classes over the years, and now I'm the TMJ specialist. I don't think I'm a specialist, but I have a lot of experience seeing hundreds and hundreds of patients. Some of them haven't gotten better, some of them have. Moved it into teaching a class for patients, which again is just that we are not a class-based profession. We know that, but I have found that having, again, an understanding of anatomy and treatment approaches and the common causes and effects, most of my patients are really happy after that class. And then it can be a building block. Obviously, some of them are not going to be because they need more. And the way I talk about it is like when I teach a class, just like you guys, it's a foundation, and then we build on it. But most people need a basic foundational understanding of what's going on with their jaw, how their head and neck is contributing, how it's not just a dental issue. And then from there, right, we can build on that, but understanding that. So that's what we're going to do today as well, is have some foundational principles. Any questions for me? Anything else? I think I mentioned one name. I don't think I have it somewhere. Roccabado, Rocabado, Mariano Roccabado. He is one that I was able to take some in-person. He's kind of like, if you thought of the Maitland of TMJ or the Stanley Paris of TMJ, he's kind of the guru. So fortunate early in my career to take some in-person courses that he took. And then he has a long series of courses that you can take online through St. Augustine. So that's Stanley Paris's school. So I went through kind of extended courses through there. So a lot of this I would attribute to him, and then built on that through other Con Ed courses, and anything that comes up on MedBridge, on TMJ. I'm always taking those just to get fresh. AOMT has had some great stuff on it over the years as well. So with that, what is, again, I think this is helpful, even with understanding where does this come from. And it started with it was a dental thing. It started with dental research. It started with dentists looking into it. And so what they were talking about is how can we restore the least amount of pressure on the joint, which that concept makes sense. And I think that's what we want to do, whether it's at elbow, cervical spine. How do we make it to where there's the least amount of friction happening? So a good idea, but once again, all they were thinking about was the joint itself. And then, so what do we want to do? Facial pain, ear pain, headaches, all of this though is coming from dental malalignment. So as we look at the anatomy of the joint, it can be that if your teeth are not in, so I was looking to see if I could find the school that was such this guy, his jankiness. He's had a few manipulations. But you could see if the teeth alignment is off, that's gonna affect the jaw alignment, correct? So conceptually, yes, makes sense, and it can be a piece of the picture or the puzzle, but they're making it to where that was it, with their understanding of, they're looking very myopically at just the teeth. And so that's where it started. So you can see, realign the teeth, they should get better, dentist treat it. And so the problem is that a lot of people didn't get better, especially as you go to only thinking about teeth alignment in regards to restoring proper or that least amount of inner joint pressure. So I mentioned this, varying terms, some people call it a disease. I would try to stay away from that word because if you take your chronic pain courses, disease is not. So I like to use with my patients TMD. So and the D being, anybody know what the D would be?
Dysfunction.
Disorder or dysfunction, but even which one sounds worse? Yeah, disorder is like, oh, I'm disorderly. And so the least scary medical term I think is TMD. And so that's what I emphasize with my patients is you have a temporomandibular dysfunction. So things aren't working as well as they could. But we can improve that. This is and all stress. It's not a disease because most people think they have something that needs a specialist to treat. And so what I'm often trying to say is there's things that you can do to help this, giving them hope. As I mentioned, craniofacial pain, orofacial pain, and as I was researching this last week, just getting fresh, there's way more I could have added. So don't be surprised if there's a new term. What in the world is this? Cause of craniofacial pain. Well, so the joint itself, that is a contributing factor, but the muscles are going to have a contributing factor as well. Psychosomatic contributions. There is a reality, and I'll talk about some of the most recent research of what's the most evidence-based treatment approaches for this, and cognitive behavioral therapy is still on the top. But that's not all. It was fascinating for me when I started the idea of doing the TMJ class, and so asking around if different service areas for my patients had one, and there's a TMJ class in Santa Rosa as well. And so if you're a paid member, Kaiser in Santa Rosa, and you have temporomandibular dysfunction, you'll be referred to the TMJ class, and you take this one TMJ class, and then you take 4 classes with behavioral health on understanding your brain and all the things that behavioral health does, and then you can see another provider. So I think they went a little too far, and so I chose, I'm not going to go that far, but there is a component, and so I try to educate patients that could be a piece of the puzzle for you, understanding and explain cortisol and its relationship with pain and stress, and so you may see that, but it's not that's all that it is. The disc, we'll talk about that. We already mentioned occlusal malalignment. So the consensus now, though, is saying just like a lot of our body, I mean, you could say the same thing about the knee. Initially, it was all probably about the meniscus or, again, the intra-articular structures. Now we understand muscles. We understand functional regional interdependence, with a lot of stuff out of USC, how the hip is having a relationship with knee dysfunction, how you can have lumbar spine referral into the knee. I like to think of this the same way within the jaw, is there's a lot of related. The other thing that I like to treat is shoulder cervical dysfunction. Just that complex clinical reasoning of is it more cervical, is it more shoulder, are they related to one another? Can be challenging, but it's a good challenge. Same thing again with the jaw is often you're going to see a cervical at least component. So then what percentage is it? Is it 80% local, 20% to 40% muscle, 30% joint, 30% psychosomatic, right? So having again, this is the fun part of what we do. And it's hard, and we were just talking about that in mentorship yesterday, right? This is hard. When I was in the fellowship, I was telling Ryan, I did not like it, just to be transparent. I was like, I like inpatient. I'm comfortable. My patients like me, and I can get in and get out, and I don't have to think about my patients at night. And then I got into the outpatient world. It's like, these people want me to figure out what's going on right now, give them an answer, and it was a grind. And then even after I got done with the fellowship, it was a grind. Did I choose the wrong career? Honestly. And then just sticking with it, and some things started to click. And I genuinely like it, 80% of the time. So it's good. It's just, it is hard, thinking the complex. But that's what we're training you to do, is understand there's a lot of different things that could be contributing, and then helping and this is the other piece, because what patient doesn't want it just simple. What's the one thing I need to do? They want a surgeon to fix them. They want an injection to fix them. They want a medicine. They want you to do one thing that's going to fix them, and helping them to understand that most of the time it's not that simple, and getting them to buy into that, to trust you. It's all part of it. And so that's where, once again, in these lectures, if you come in confident with an understanding of the anatomy and being able to explain things to them, even if you're BSing them half of it, try not to, right? But if you go in confident, and you're not lying to your patient, you're just trying, based on the anatomy of what I remember, this is what I think's going on, and so this is what we need to do. And then if that doesn't work, you can pivot if you need to, but helping your patients to understand. So the other piece is, you can see the literature doesn't support that occlusal relationships cause TMD, and I think this is really, really helpful, because again, when we are looking at the dental world, the orthodontic world, what they're going to focus on is perfect anatomy, right? You guys, most of you know I have 7 kids, had a lot of orthodontic bills, and I'll never forget seeing one orthodontist and his spiel to my child about how he can make her face look better, and how her alignment in her jaw, and we need to do this surgery and this surgery to get things in perfect alignment. And we had a pretty decently heated discussion about anatomy, and is the goal to make all anatomy perfect alignment, or are our bodies very adaptable, and that, again, perfect anatomy is not always what we're looking for. And so I use the example again of, does every person have to have a perfect arch in order to function well? I would say no, right? Is it okay to try to get people in a good neutral position? But there's some people that are actually going to function better with a little bit more flat feet or a little higher arch. And if you start monkeying with things that have been there for a long time, that's their anatomy, then you could actually cause more damage than benefit. And so, because the research is not supporting it, like most things, as you know, at least as an entry level, even if anatomy is off, surgical intervention. Again, it can be appropriate, but as you know, with a lot of different, you guys are PTs, I don't have to tell you this, surgery's not number one to go to. So I love the Maitland concept of the semi-permeable brick wall. And it's very obtuse, but and I'm not that type of person normally. I'm not, but for some reason this helps me. So I have some things on the slide. But how would you guys remember that concept, Maitland semi-permeable brick wall? Anybody remember it? kind of right from the beat, yeah. So it's this visual that Maitland gives, and so what he's trying to say is, what we're doing as PTs is we are trying to look past the surface to see pathoanatomy. Does that make sense? But can we absolutely see pathoanatomy? No, we can't see exactly what's going on, but are we working hard to understand pathoanatomy? But even that, is the pathoanatomy always what's causing their symptoms though too? So even if we had X-ray vision, an MRI, understanding of exact the pathoanatomy, that doesn't mean that we treat just exclusively based on pathoanatomy. And so that idea of, I want to work hard, and you should want to work hard to understand, and this is where we push you, every day mentorship, what are your top 3 pathoanatomical differential diagnoses, don't we? But again, that's only a piece of it. We want to look past to try to get there, but there's a lot more to it of treating patients. And so we're going to be doing that today. So again, mindful of suspected pathology while treating the signs and symptoms around that. And so again, I think that's helpful of, sometimes we can lose the forest for the trees. We get so myopic in looking at the individual pathoanatomy, and to take a step back. And what's the big picture of this patient? Well, the big picture is you've got a ton of stress, and you got some fatigue, patient we had yesterday. You haven't been exercising, and so I could give you a little exercise for your jaw, and it might help your jaw a little bit. But if I'm missing the big picture, we want to be holistic, and again, people appreciate that. I'm not discounting though this. Does that make sense? But I'm also helping them to see that this is a part of a big spectrum, which is your whole life. And so that's the other thing, is a lot of people don't recognize that. And that's one of the other reasons I love being a PT, is we get to open people's eyes and be health promoters. And you wouldn't think that a jaw could allow that, but it can. It can be a window to opening up. There's a lot more behind the scenes, and we can be great health promoters. So you could say, dang, I can't cure or modify disease process. Well, again, we know that, which is why conservative treatment is preferred. So then, a question that's been, why physical therapy? And so you can see anyone can teach exercises, educate, but our knowledge and skill is manipulating the arthrokinematics. In manipulating, the arthrokinematics makes us the treatment choice for craniofacial pain. So once again, anybody can yank on a joint, can't they? But why are we yanking on that joint, and how are we yanking on that joint? And is there some specificity to what we're doing? And the hope is that you would say yes. And then once again, cervical spine being a lot more support. So this epidemiology, it's just crazy the amount of money that's spent. And I didn't trust my slides. I'm like, these guys got to be too old. And some of them are my references. So I was digging to try to, you know how it is, it's hard to find these types of numbers. But the second bullet point, this was, I didn't put it in there, I put it later. This is a 2023 research study. Second most common musculoskeletal chronic pain disorder after low back pain. Crazy. Like this is a big deal. 6 to 9% of adults globally. Many have, so this is another interesting factor though, that many have signs and symptoms of TMJ but don't seek treatment. And so I mentioned this in my class to patients, partly because there's some people that they feel a click and they think the world is over. And so to help people understand a click, you know, I mean, if you wanted to feel my knee, there's quite a few clicks happening right now. Does that mean I have pathology or I have dysfunction? And I'll literally have people feel my knee. I think it's helpful, right? And I'm a physical therapist, I exercise as much as I should, but that doesn't mean there's a problem. So to help them understand that, once again, anatomical differences, it's just like the research studies that you know of imaging for low back pain. A lot of people are going to have poor imaging. A lot of people are going to have some dysfunction in the function of their joint. But again, does that mean that they need a lot of treatment? And you'll find, there's some, the dentist that we have is in his 70s and very sweet, and every time he does his detailed TMJ screen and does a nice little massage to check for any lymph nodes and his oral cancer screen every single time, and I'm like, oh my goodness. And he's going to send you his patient if there's a little click, even if they have no pain or no dysfunction. Does that make sense? And so to ease some of those fears, and maybe there is some impairments that you can treat, but not being overly concerned about that. Yeah, so you can see 50 to 75%, it's huge. So this is a young, middle-aged adult problem. Women outnumber men 2 to 1. 85 to 90% of the treatment populations. I always feel weird that I'm the guy that treats all these young ladies, but it is what it is. That being said, this Bush's pain sensitivity, personality profile, and presence of illness behaviors, there was no difference between men and women. So it's not like women are, again, more sensitive to pain, or again, there's a personality issue, or again, presence of illness. I think it's just some ladies are smarter than guys and actually go get treatment, and guys are dumb and don't do that. But yeah, I don't know. Do you guys have any other thoughts on that? Why more women would seek out treatment than guys?
I think the stress is part of it, and societal expectations. I think we could get into a whole long discussion on that, but
Yeah.
pressure and pleasing, all these things that are different for women.
Mental load
Yeah.
for women.
Right.
For
Yeah.
sure, for sure.
Okay, that's good. And then we'll talk about this last. Rockabato talks about musculoskeletal problems start at a very early age as a result of postural aberrations. And this was a fascinating one for me, but as we get into it a little bit more, it'll make sense in regards to those formative years as a child and what's happening during those formative years, and what's being developed as far as postural strength and even positions for the head, neck, and even the jaw. So this is my warning. If your jaw wasn't hurting ahead of time, it certainly will. So with that, how are we doing time-wise? I know you guys are sitting. Let's go ahead and just take a quick 5-minute break, and then we'll keep going.